So Lulama, I think we can start if I get an okay from you. Or do you have colleagues who have not joined?
Hi Helga, I think I was expecting around 20 people to join today, so I think you can go ahead and start if you're ready.
Okay, so because of time, I think allow us to start this meeting today, and we are very happy as Kenya to host this very important webinar. So thank you very much. Allow us to distract you when it comes to distraction because of working from home. But thank you very much. I think this is a collaboration between countries and the South-to-South HIV Learning Network. And today our topic will be differentiated service delivery models for key populations. And just to give a background is that there are many countries that have taken this role of implementing the DSD for different populations. Whereas today we are talking about key populations, we know countries that have implemented DSD among other populations. And in many countries, when you are starting programs, we know that we all started doing DSD because of the scenarios that we had. So today, as Kenya, we are very happy, and I would like to thank the SSLN team. I want to thank the Kenyan team. We want to thank our Tanzanian, Nigerians, and Zimbabwe colleagues, and the organizers of this SSLN network, because this really has been a very great platform where countries have been sharing good experiences. And we also know, for those who can remember, we went through a very rigorous exercise where we were doing the PSATs, and this was really very good, where countries had to reflect and self-assessments were done, and we were able to identify our gaps. The network is therefore focusing on the gaps that were identified by the country to really prioritize some of the areas where we can benefit from each other. We know countries are doing very well in the different interventions, in different service delivery models, and in different innovations. And that's why this platform is really key to really bring us together and to enable us to learn together. It calls for dedication, it calls for time off your working schedule, and most of it is on volunteer. So we know that you're not being paid to be in this network. So basically, it's out of your self-will that you're in this network, and we are really, really happy that people have really dedicated their time to really cooperate with the team and bring up some of the big topics and good topics as a country. The representation for the teams were really considered very well. And we have a mix of government agencies, implementing partners, community organizations, among others, our donor agencies, the UN and the UN family. And we are really, really happy that we've been able to move. Thank you. So congratulations to the team and the hosts for these virtual webinars. So we're very, very, very happy. So today for the agenda, and thank you for the person moving the Lama. Thank you very much. I'll take you through the agenda, and then we'll go straight to the presentations so that we can manage time and have more time to have our discussions. We are going to have a presentation, and I'll not go through the details because this detail is what has really facilitated the people who are doing the presentations really to go line by line and answer some of the key questions. But part one for our webinar today, we'll be sharing the promising practice, the why and what, and that will be taken through by one of our colleagues who is in charge of the coordinators of HIV in Kenya. We have 47 counties and we have 47 coordinators of HIV. And Dr. Mike Ekisa is the chair of the 47 counties for the HIV response. And this is at the county level, and the county level works very closely with the national level. Then we'll have part 2 that will be taken by one of our implementing partners who are the pioneers in the DSD and champions of key populations programs in Kenya. And we'll also have the same time having one of our community-led organizations that is also doing very well in terms of delivering services for the MSM. And you're going to hear practical insights from from these presentations. And then we'll have an open session where we will do reflections on the presentations, deliberations on the adaptability of the interventions and how this can be tweaked to the different contexts if we are not doing that. But we know that majority of these interventions are actually being rolled out in your own countries, maybe in a different way based on the context. And then identify of conversations to follow up across the countries, within countries. And just the same way we've been identifying gaps through this network, we'll do the same to ensure that we follow up and we are able to replicate whatever we feel is a best practice from one country. And then we'll have a summary of the commitments and next steps. And we'll have participating countries really sharing their own takeaways. So I will lead that. With me, Janet will be supporting me, who is a member, and my other team members. And we'll also have Yulama really helping us and helping us and guiding us in the way we are going to go. We would have allowed everyone to do introductions, but because of time, you'll be able to do the introductions when you're really doing your question or you're doing the presentation. So karibuni sana. That is what we say in Kenya. Welcome very much. And my name is Helgar Musyoki. So that I don't speak when you don't know me. So thank you very much and welcome to this webinar. Lulama, do you want to go to the next slide? So we are going to invite Mike Ekisa, and Mike will also tell us about our Kenyan HIV program and why we feel that the DSD models have really helped us in terms of scaling up some of the interventions. But just to remind you, Kenya, we still have the key populations being the drivers of the HIV epidemic. And for the longest period, Kenya was actually responding to the general population epidemic and somehow had forgotten the epidemic that was being driven by the key populations who are the sex workers, the MSM, the transgender, and the PWIDs. And it was a wake-up call back in the 90s when PEPFAR brought in the first seed funding. And as a national program, we took over in 2008, and Mike will be telling you all about all that. And therefore, we started focusing on really interventions that are targeting the key populations. And for us, we would say it's a game changer. We keep on learning and we keep on tweaking our interventions based on the advice we get either from the community members, from the implementing partners who are implementing these interventions, but also aligning that to the policy environment that we have in Kenya, because you all know that for key populations really to succeed, then you need to have a very good enabling environment. So thank you to our donors and our partners for Kenya who've really enabled us to go through this journey. So at this juncture, allow me to welcome Mike Ekisa, who is a very seasoned HIV programmer and has a wealth of experience in HIV programming. And Mike will be taking us through the first section. And then after that, I'll introduce the other members. Thank you very much and welcome, Mike.
Thank you very much, Helga. Just to check with you that you can hear me.
Yes, and we appreciate your background too.
Nice. Thank you, Helga. It's Kenyan. So Helga, you'll be checking for me. Should my mic have a problem, please alert me.
Sure.
Thank you. Other colleagues, our visitors from other colleague countries and our own team in Kenya, good morning. For here in Kenya, we're in the morning. And thank you for joining us. We are honored to be part of you this morning in this beautiful discussion of DSD in KP programming. My name is Dr. Mike Ekisa. I manage the HIV program for MAAYGO, and I lead my colleagues across the country, as Helga has introduced, and proceed directly to our first presentation this morning. Start by giving you the context of HIV and KP programming in the country. And it's good to emphasize that Kenya has an interesting HIV response program where the epidemic is both generalized and concentrated. This in the background of about 1.2 million general population who are living with HIV.
And see when we'll be using the modifier.
Thank you. In the background of about 1.2 million general population and about close to 300,000 key population living with HIV. And the key population here is very critical to our HIV response programming, because we know that they contribute to 30% or more of our HIV incidents annually, either directly among the key population themselves or through the GP with whom they interact in the course of KP concerned activity. Our key populations in the country are 4 for now. We have majorly female sex workers, followed by men who have sex with men in the numbers, followed by PWD, the persons who inject drugs, and a small number of transgender population, though growing. From our latest key population estimates, we have close to 200,000 female sex workers at 197,096. We have a range of MSM with a higher limit of 61,650, 27,056 people who inject drugs, and 4,000 transgender. The first 3 estimates are from our 2020 KPSE, and our transgender population is from our 2018 KP size estimates. We have relatively high HIV prevalence among our key populations, with a range of 18 to 28% from the FSW to MSM, with PWD in between. And this makes this population group very significant in our programming. The background here is still in a country where sex work, drug use, and same-sex relationships are criminalized by law. And these are all important dynamics, especially that lets a platform for a big need for advocacy components in KP programming. Let's do the next one. Great. Our KP response in Kenya is government-led, community and stakeholder involved and supported. So the Ministry of Health with NASCOP, our NASCOP is National HIV AIDS and STI Control Program. Within the Ministry of Health, the technical program. And we have the NACC, which is our National AIDS Control Council, which is a parastatal within the Ministry of Health, tasked with multi-sectoral engagement and policy. So these 2 organs give us direction nationally in terms of strategic direction, standards, technical support, policy formulation, both periodically and annually. And implementation happens at county level, and we have very empowered county health management teams that support the national teams in implementation and support supervision directly while working close with our partners, implementing partners for the various agencies, especially of PEFA and Global Fund. We mainly have funding through the government of Kenya, Ministry of Health and Counties, and through the PEFA heavily and Global Fund heavily. We still have other donors who come our way when we have potential grants, to mention the Johnson & Johnson and many others through LVCT and other partners. As of December 2020, we are doing about 87% of our close to 200,000 FSW having been reached with prevention services. That's around 170,613. We have an excess reach of the MSM community with about 105% of our higher limit of our KP estimates of 2020. And our MSM programming has done fairly well. We are about 67% for the reach of persons who inject drugs, working in 11 counties. We are working towards scaling this up to the other counties in the course of this year. Probably this will help us to raise the reach of this community. And as part of service to the persons who inject drugs, we have the methadone-assisted therapy, which is really a rehabilitation therapy for PWID. We currently offer this in 6 counties, reaching about 4,000 of our PWD. A snapshot to our KP program from a policy to a service delivery level at the moment. Next slide. Thank you. So why DSD in KP? It's good to mention that our differentiated service delivery for KP first comes in a background of a very rich DSD for GP. And the lessons learned therein and the needs seen in KP are just translated to us scaling up DSD approaches for KP. And this is basically to respond to the variety of need of KP, tailored to the needs of KP, the risks involved, the needs of the subpopulations, so that we can't give a one shoe fit all sizes for FSW and MSM and PWID, as well as the need to provide comprehensive prevention packages despite these settings. It was still to help us make these services more accessible and more appealing, more acceptable to the KP population, irrespective of the timings that are convenient to them, locations where they live, and heavily with consultation of our KP community. And this sets the background, and as you see the next slide, basically to try and meet the diverse needs of our KP community, while being careful not to overburden the healthcare system, and try to meet the KP according to their preferences from their engagement. Next slide. Yes, so from the factor that informed our DSD, as I just mentioned, it's mainly threefold. One is the diversity of KP, where we have different subpopulations that have different needs that can be met with one metal fixed rigid service delivery model. On the other side, with the growing reach of our KP population, came potential strain on the service delivery system, especially the DIC and safe spaces. So there was need to tailor these services to KP where they can be found. And there came COVID-19 that really pushed the need for innovation to maintain the service delivery for KPs. And so in a summary, DSD, just extending the approach we've used in our GP, is a client-centered approach to try and give access to our services to all KP where they need them, while reducing the burden on the healthcare system, while respecting the diversity and the preferences of the various KP typologies. That is the why for our KP DSD. Next slide. Okay, thanks. So we'll break down our DSD approach to when, where, what, and who concept. So making our KP prevention services differentiated involves tailoring them to times that suit the service and the KP typology. So the result, we have daily services, like when you look at the where, our drop-in centers are open daily. We have weekly services, especially for outreaches, which are tailored to peak days of the week, day and night, as applicable to KP typology. We have monthly services, such as condom distribution, peer-led. We have quarterly services at client level, such as a clinical encounter. And we have rapid result initiatives guided by data. When we find we are lagging behind in a strategy, part of the 90-90-90 in a prevention component, then we design a rapid result initiative to scale up that particular service to a KP typology group that is left behind. to a region of the country that is left behind. On where, as I've already mentioned, some of the tailored services to time will be delivered in facilities like the drop-in centers, public health facilities. We would have mobile vans, we would have services to community, to hotspots, the diversity of bars and clubs, hotels and restaurants, to virtual spaces, dating sites, to homes, in diversity of where the KPs can be reached as expressed by the KP. The services offered alongside when and where range from our prevention package for KP, condoms, lubricants, especially for MSM and FSW, needles and syringes targeting PWID, STI services for all, HIV testing for all. We try and give this to all our KP quarterly, even despite the global cut down of HIV testing kits, with innovations such as HIV self-testing, provision of ART for all who are confirmed HIV positive, provision of family planning services to KP integrated to wherever KP are accessed, psychosocial support and violence response support, as well as structural services like advocacy to the law enforcement authorities. By who? Also tailored to the service. In our DICs and clinics, we have clinicians, nurses, healthcare workers, counselors, providing the tailored service to the client. So we have a one-stop shop in the DIC, we have a one-stop shop in the outreaches to community, with the clinician to give the clinical services, the STI services, the HIV ART services, with nurses to give the FP services, prevention of mother-child transmission for KP who are living with HIV, counselors to give counseling services and testing services. We have heavily peer educator services and outreach workers who keep interacting with KPs on a day-to-day basis from the hotspots and in the community and households. That slide gives you a nutshell of our differentiated service delivery concept for key populations. Next. Well, especially brought about by the challenges of COVID-19, HIV self-testing turned out to be one of our models to maintain our policy of quarterly access to HIV testing for all key populations in the country. And as a result, we biased the available HIV self-test kits to prioritize our key population programming. Access through the DICs, drop-in centers, sent out through peer educators to reach all KPs at community. Amid the raging COVID-19, we still know KP activity continued. So we had our peer educators deliver a self-test kit as part of the package to the community where they were to enable them to know their status and the status of their clients, of course, with good advice for those who test positive for the screening self-test kit to access either the DIC or the facility. In a mix of strategy, this supported us to guarantee KPs to continuously know their status, as well as from the comfort of their homes and hotspots, allow their clients and contacts to know their HIV status. This is a model and one that we look forward to scaling up, sustaining, and would heavily recommend the global KP program. Next slide. The design of DSD involved a very consultative planning, and you'd easily replace the word involved to involves, because this is an ongoing process, often with KP community involvement, like even in this meeting and in this championship, to prioritize the needs and the appropriate tailored responses to KP needs. This has been cascaded to technical working groups and committees of experts to fashion in the needs that are established from data, from evidence of research, from the KP community, to intervention that are structured and build capacity of the KP program across the country to deliver the targeted KP intervention for tailored to specific population groups and settings. Implementation heavily involves advocacy, knowing the background of legal perspectives of KP within our country, engagement with national and county leaderships, mentorship of staff, and then documentation of services provided. Then ongoing monitoring of KP programming on a monthly basis, mainstreamed to our national Kenya Health Information System, on a quarterly basis, and accountability from the KP program partners, the national KP program. And this helps us to keep identifying the priorities from data, where need to be scaled up by RRIs, where needs to be tailored in continuing routine implementation. Next slide. Well, the factor that facilitated our KP programming is one, existence of clear national guidelines on implementing DSD, starting with the background of a very strong care and treatment DSD that gave a very leveraging ground to develop our own for KP programming. And one of the guides is shown here, responding to violence against key populations to promote access to HIV services. This tailored to the need for violence response with enough structural interventions. And we have this cross-cutting, including overarching key population programming guidelines. We've had advocacy with stakeholders, especially law enforcement, donors, and management teams at national and county level, the networks of key populations. Capacity building approaches has been a strength in our program. We have tailored training curricula for various key population program needs, well steered by the national program and networked across the country. So whenever we identify a need across the counties, we'll ask the national key population program and get TOTs and get curriculum and administer it to the needful staff across the country. We have SOPs for various key population services across the Cascade, including peer education, including provision of condoms, STI. We have technical support from government to implementing partners, and still the other way around, where implementing partners have something extra to offer. We have room for that provision. We have a very efficient coordination mechanism led by the National KP Program and the National KP TWG that cuts across for all stakeholders, all implementing partners, and all counties. We have room for client feedback mechanism. KP TWG is one forum that allows the community to give raw feedback to both government and non-government agencies. And a robust monitoring system with the climax being integration to the national HIS 2 years ago, and a maturity of reporting now to near 100% on timeliness. These have laid a rich ground for implementation of KP interventions tailored to need, to context, and that is equal to KP DSD. Next slide. A small look at data. All these attempts to tailor KP interventions to KP population groups and contexts would say has worked towards good progress in achieving targets for KP interventions. And yes, at the moment we are experiencing very low numbers of new infections among KP who have been in programming. And we could attribute this to the strong differentiated models of delivery of KP prevention services. So quickly looking at the prevention cascade, we take here an example of the men who have sex with men. Our highest limits for MSM reads at 61,650 estimated men who have sex with men in the country. And our program currently has contracted 105% of that, 64,873. And when you look at our report by last quarter, Close to all of them, slightly above the estimates, received peer education services and received condom programming and condom services per need in the last quarter. We have slightly low reach for STI screening and HIV testing, and we attribute this to the challenges of COVID-19 limiting contact. As you know, with HIV self-testing, it takes time before you get feedback from the clients who have self-tested. So we have about half of our KPs accessing testing and STI screening in the last quarter, that is October to December. In the treatment cascade, we have an estimate of 6650 HIV positive MSM. Out of this, we have reached about 78% who have been tested and known their status. And out of this, we have put about 82% of them on antiretroviral treatment. And 2581 for the last quarter were eligible for viral load testing. And we had about 90% of them access a viral load test with a suppression of about 75%. These are hard indicators for KP typologies, especially amid COVID, but we are there and telling through, despite COVID, through the low fruits of differentiated service delivery for key population programming. Next slide, please. Well, to end off this part of our presentation with a few recommendations. 1 and 2, ensuring an enabling environment through 1, provision of policies, guidelines, and SOPs, so that implementers don't guess what to do in the midst of diversity of needs and context of KP implementation. Very important. So the National KP program needs to continuously take lead in developing the policies and guidelines to respond to different KP typologies in different contexts and different needs, including violence. And very close to that, coming second last in our list here, invest in advocacy at all levels, so that you have an enabling environment structurally. The number 3, strengthened coordination mechanisms. KP is a very delicate program, but very easy to manage if you get the art of coordination. Mapping out your country to see how your country administrative structures are fashioned and have everyone on board, have all the levels of government represented, have all the levels of partner and donor implementation represented, and have, more important, community represented. And the community should be represented not just for numbers, but to really inform you what they need. When you go that direction, where you don't involve the community for convenience, but really involve them at every stage, including the beginning, to hear what exactly do they want and need. Then let that inform your technical discussion, still with them represented. It gives birth to good tailored mechanisms for KP interventions. Invest in a strong monitoring mechanism for key population program to capture all the tailored services. And one of the strongest lessons from Kenya is mainstreaming KP M&E to the national MOH M&E. And that will be a secret for any country to adopt, that eventually it leads you to becoming less and less partner dependent and more government and community. And that, of course, is the field of all HIV prevention programming. In line with that sustainability plan, there's definitely a need for all of us to start allocating more and more resources and designing more innovative ways of domestic resource mobilization to sustain service delivery to KP, knowing that if you don't do it, we'll keep fueling the HIV epidemic. And then finally, something well done in Kenya, adopt research and implementation of pilot project recommendations to KP programming. Thank you very much. I think this was the last slide for this part. You can see the next slide, please. Yes, thank you very much for this minute. I'd like to hand it over back to Helga.
Thank you so much. Thank you. Thank you, Dr. Mike, and thanks for that well-articulated presentation on our part. We'll allow for questions at the end of the day. and we'll allow all of us to have our reflections. But for now, allow us to go to part 2 that will be presented by Onesmas Musau and on the how, and we'll give an example of an FSW model. And Musau is a seasoned implementer for a very long time and one of our champions in Kenya, and works for one of our organizations that is funded heavily by PEFA through CDC. So welcome, Musau.
Thank you very much, Helga, for that deep introduction. And it's a privilege for me to be able to share in this forum. So I work for LVCT Health, and we implement HIV programs, among other programs. Our target population, key and vulnerable groups. And as we realize, for us to reach these people as we should, then innovation such as DSD is much needed. Let's go to the next slide. So I'll be sharing with you how we implement DSD among the female sex workers. So as you can see, how we adopted this, but first, just why we implement DSD among the sex workers. First is because of their mobility. They move from time to time from one place to another. And so they may miss out on clinic appointments, and that makes them miss vital services. Program data, that is our program data, pointed out to poor clinic visits or treatment outcomes among some FSW. And so again, this necessitated DSD. Some FSW were unable to access clinics due to distance. First, not all sex workers live just next to the drop-in center or the facility. Yeah, and then secondly, also because of COVID-19 restrictions and the lockdowns. And then high volume FSW clinics implemented DSD in order to avoid crowding in clinics, and basically because of COVID-19. Now, how we adopted the DSD model or models. First, our teams were trained by NASCOP, and there are several trainings that NASCOP provided to our team. And one of the teams is actually the dissemination of the SOP on DSD. And then the program used the program data to profile FSW or sex work or female sex workers who would benefit from DSD. Depending on the uniqueness of FSW needs and settings, the program determined the DSD models to implement for each group of FSW. The DSD models were adapted at both facility and community level. Next slide. Now, some of the activities that were implemented under DSD, and this slide is particularly about all female sex workers. In the next slides, I'll show you DSD among the HIV positive sex workers. And the first one is just the peer education and outreach program, what we call the peer-led model. And the program identified peer educators from the sex workers community. Basically, all peer educators, majority of them are based in the hotspots or where sex work takes place. The peer educators were trained, and it's important to note that the part of the curriculums that NASCOP has developed is the sex workers peer educators training manual that we use for the trainings. NASCOP also has a pool of certified trainers that we use during these trainings just for standardization. And then peer educators, after the training, they mobilize their peers for HIV services. And we have a national guidelines that recommends a peer ratio of 1 peer educator reaching between 60 and 80 sex workers. So the trained peer educators conducted the outreaches in the FSW hotspots. It's important to note that these are peer educator organized or led kind of outreaches where there are no clinical services. Now, services provided here include health education, condoms and lubricants, and then they also do referrals or referring their peers to clinical services. And then the peer educators are trained and they've been supported to be able to do monthly reports, just to report the work that they do. And then program jointly with NASCOP continue to provide technical support through monthly supervision of these peer educators. Now the program supports peer educators technically, but also provides monthly stipends and transport to the peer educators. And then the other model I will talk about for sex workers is the integrated outreaches. It's important to note that we have drop-in centers. We also have integrated government facilities or public facilities which provide KP-friendly services. But not all sex workers come from that surrounding. Some sex workers will come from some distance. And so hence the need for integrated clinical outreaches. Now, how this is done is that all clinical team, again, is trained by NASCOP. And then the program mapped out hotspots that are distant from the diocese or the static, the facilities. And then that mapping helps us to know the places where clinical outreaches are needed, people who would otherwise not have made it to the facility. Then peer educators jointly with the diocese or the program team from the hotspots develop the outreach work plans. On the day of the outreach, the program hires rooms within the bars or lodgings or hotel rooms. Well, some of the lodgings may not have adequate space. And so in such places, the program gets tents and pitches the tents and uses them for clinical service provision. Then peer educators mobilize their peers for clinical services. Then the program provided clinical services. Within the guidelines developed by NASCOP, there is a package of services that programs are expected to provide. And part of these that are provided during outreaches is the STI management, HTS or HIV testing services, family planning services, the TB screening and referral, among other services. And then the data is recorded in NASCOP developed tools and also later entered in the EMR. Next slide. So I want to present some models that we implement for HIV positive sex workers. And the first one is what I'll call DSD by location. And in this one, HIV positive sex workers who have difficulties accessing the clinic are profiled and listed or line listed. Then the difficulties that I'm talking about ranges from mobility due to sex work. Some sex workers who travel from Nairobi this month and go to a different town, and they have a schedule. They will come back to Nairobi after 3 or so months, and these are the difficulties I'm talking about. We have some sexual partners who restrict or resist sex workers from visiting the facilities or taking certain services. And then, of course, there is issues of lockdown due to COVID-19. Then these FSW were contacted using DICE phones and appointments scheduled for drug disbursement and client review. So drugs were sent and delivered to the clients using an organization-owned motorbike. Some clients who are in a position are also able to support the transport of these commodities. And then clients, once they receive their commodities or their drugs, their ART, then they're able to call back and confirm or send a text to the program and confirm receipt. Then there's also what we call the client-centered ART groups. Now, these are groups that are formed by the community or by the sex workers themselves. Each group has about 10 to 20 members, and the groups develop drug collection schedules, and they assign one of them to collect drugs from the facility after a given period of time. So they take turns collecting drugs, and taking them to their group members. So the clinics, on the date when the drugs are supposed to be picked, so the drugs are pre-packed. There are envelopes with the names of individual group members. Then they are put packed in one package, which is then given to the group member who comes to collect. And then they go distribute the envelopes or the drugs to their group members. And once a group member again gets the drugs, they're able to communicate or send a text to the program just to confirm that they received. Next. And then we have, other than the community-led groups, we also have the health worker-led groups that work almost the same as the community-led groups, just that in this case, it is the healthcare worker who takes the drugs to the members or to the group members. So I want to repeat because the other details are almost the same. So I want to go to the fourth model, the long appointment model. Again, just like I said in the beginning, sex workers are mobile in nature, and there are those who, for one reason or another, will not be able to come back on the scheduled dates for their drugs or for their prevention commodities like condoms, PrEP, and the like. And so for this, we implement the long appointment model. All clients on ART were categorized by level of stability. So there's what we call the stable ART clients. And these include those who have taken ART for more than 12 months, those who are virally suppressed, those who are not pregnant, their BMI is more than 18.5, they've completed IPT, they have no opportunistic infections, they're more than 20 years old, and there are no healthcare worker concerns. So this group is put together and enrolled in the long appointment model. These are given drugs and prevention commodities for up to 6 months, depending on their level of stability. This model does not only apply for ART, it also applies for things like condoms and negative clients who are on PrEP. Next. In terms of achievements from DSD for sex workers, I'll be able to show you not really the entire cascade, but our achievements in this current financial year that runs from October. This is data from October last year to March this year, basically 50% of the year. And as you can see, those who have been reached by a peer indicator out of the ever enrolled cohort is 74%. If I showed, this is a 3-month period. If I showed the 6-month period for such, then the achievement is over 80%. And then the program is expected to reach 13,429 sex workers with clinical services. And out of these, at 50% of the time, we were able to reach 72% of the target. And other achievements that we can talk about is the quality and reliable data that comes from the community, from the peer educators, whether it is the groups for HIV positive sex workers, or whether it is the peer educators when they're submitting the data about the work they did. And the data is used for program improvement in what you can refer to as the CQI approach. And then the peer indicators are supervised each month for quality improvement. Peer indicators mobilize sex workers for all types of, from all types of hotspots. And some of the hotspots are not the usual. So we have also of late worked in virtual hotspots. Next. Now this is data for the month of, or DSD for HIV positive sex workers. Okay, this data is not just for sex workers, it includes some data for MSM, just note that. And so the stable clients within the month of March were 1,021. Now those who were put on the long appointment model were 317. Those who were virally suppressed out of the 317 is 92%. Just note that this is not the suppression rate as it is known. This is the denominator in this is the total number of people in that model. Otherwise, if I talked about suppression, our program suppression for sex workers currently is at 93%. Yeah. Now, for the clients on ART or client-led ART groups, we had 85 of them. And among the 85, 67 of them were virally suppressed, that is 79%. Then the healthcare worker-led groups, we had 291 clients. Among them, 152 were virally suppressed. And then for the DSD by location, we had 229, and 131 of them were virally suppressed. So in summary, viral suppression, as you can see, for the clients who were on the long appointment model, most of them were suppressed compared to the others. And then the DSD allows clients who experience difficulties accessing clinics the privilege to access ART services. Some clients would not have otherwise accessed these services without such innovation. Next slide. So in terms of recommendations for adaptation, DSD works well for clients who have difficulties accessing clinics. This difficulties varies, like I have said. The suitability for DSD is determined by clients or client factors. It is not program factors. And then DSD long appointments helps to ensure sex workers have services or commodities as they move from one location to another. During COVID-19 times, also DSD helps to decongest the clinics in terms of reducing the number of people who come to the clinic. And then DSD models also help increase access to health services for hard to reach population. Next slide. Thank you very much for listening. And over to Helga.
Thanks, Onesmas. Another very insightful presentation. For our other colleagues, we also get time to reflect on what we do, because most of the times, even as the world is so fast, so even as we are also articulating some of the issues further when we hear them being presented, and we also do a self-reflection. So thank you very much, Onesmas, for a good presentation. Our last part for the presentation part, we'll have it by MAAYGO. MAAYGO is one of our community-led implementing partner who are also doing an incredible job in the MSM programming. So karibu sana, Manas Migot.
Thank you very much, Helga, for the introduction. I also want to thank the first two presenters for the wonderful presentations. And without much ado, I'll proceed to the presentation. So to give a glimpse of what MAAYGO entails, it's a community-led organization situated, or rather located in the Western Kenya region, with its mandate, with the mandate of actually providing quality HIV prevention and treatment services to GBMSM, that is gays, bisexual, and men having sex with men in the Western Kenya region. We do this through different approaches, and of course, we lay more emphasis on the behavioral, biomedical, and structural interventions. Most of our services over the period have been tailor-made to address the specific needs of our key population, or other our beneficiaries. This was realized when we had a program review and we had a meeting with the beneficiaries. And of course, we realized that there were a lot of needs that were not being addressed by the previous, or rather by the interventions that we had before the meeting that we had with the beneficiaries. So we thought it wise to adopt a differentiated service delivery model so that we could address some of these needs and see if we can achieve the 90-90-90 cascade. Thank you very much. Next slide. I'll answer the question where these services, or rather where we've actually been offering the DST services to our key population, and some of the places or other locations that we've utilized are at the community level, the static clinic, the outreach clinics, and of course we also went ahead to offer these services at the homes of our beneficiaries. So to just give a short overview on the community at the community level, we are using the peer-led or rather peer education model to reach our population at the community level. And of course, MAAYGO right now has approximately 76 peer educators from different hotspots within Kisumu County. The peer educators are responsible to reach their peers at physical and virtual hotspots to do demand creation and provide condoms and lubricants, and of course, HIV self-testing kits, so that these can actually help in terms of prevention of HIV. And of course, we also address violence incidences, and we also do a lot of prevention of violence among key population at the community level. So we also have paralegal officers who've also been assigned to work closely with the outreach workers and the peer educators at the community level to ensure that the level of violence cases among key population are reduced. And of course, for those that have been identified, there's an adequate response to the incidences. The events are conducted to generate demand for service and distribution of condoms, lubes, and HIV self-testing. Last year, we were privileged to work closely with the different organizations across Kenya, and of course, with support from Partners for Health and Development in Africa, that is PHDA, to actually carry out a study on how well we can enhance HIV testing among key population with the use of HIV self-testing. And of course, this came at the period where we had the COVID-19, and it was very handy because it was one of the most innovative approaches that we adopted to ensure that there was routine testing of the key population during the COVID-19 period. Moving on to static clinics, we have drop-in centers. We have 2 drop-in centers in different regions. And of course, through the drop-in centers, we utilize the space to maximize provision of health-related services to peers. And of course, to achieve this, we conduct activities including Movie Monday, Coffee Tuesday, group therapies, and health sessions, just to encourage peers to come to the clinic. Whenever we're having these sessions, there's also they are also privileged, or rather they also have the privilege of walking into the clinic to access the HIV and STI prevention and treatment services. So we also integrate our services at public health facilities. One of our drop-in centers has been integrated within a public health facility, that is railways. And this has really helped us in terms of ensuring that there is provision of stigma-free and non-discriminatory services to our key population, despite the location that they are accessing these services from. So we're also envisioning that with sustainability of this approach, we are going to have sustainable or sustained service provision to key population beyond donor support. And of course, we're also going to claim the rights of MSM to use public facilities so as to continue the service provision to the key population. We're also embracing outreach clinics. We conduct outreach clinics in hotspots to increase access to health services at places where MSM congregate. We have different hotspots, but of course, during COVID-19, that is last year, we had some little disruption because some of the hotspots were closed down. But of course, after a period, some of the hotspots were reopened, and we continued with the outreach, with conducting the outreaches from different hotspots. But of course, this was done upon obtaining approval from the county government of Kisumu Health Department team, and of course, with the support from NASCOP. We also use the project van and motorbikes to ferry peers to access services. This is done This is one of the approaches that has been one of our best practices in the year 2020, because the van is being used either to take service providers to different hotspots so that they can offer the services and the commodities to our peers. But of course, the van also can also go to different hotspots and ferry clients to our drop-in centers to actually access these services. The motorbike is used to basically to drop service providers to different places. And of course, when we are carrying out home-based services, and of course, it's also used to distribute different commodities, including condom, lubricants, and HIV self-testing kits to our key population. Next slide, please. The next approach is services at home, just as I've mentioned before, for areas that are far-flung from the main office, or rather from the drop-in center. We use courier services to distribute HIV self-testing kits, and of course, prevention commodities, including condoms and lubricants. In addition, the bikes are used to distribute various commodities, including condom, lubricants, ARV drugs, and HIV self-testing kits to MAAYGO clients in different locations, hotspots, workplaces, and homes. This came in handy when we were looking for innovative approaches to adopt during the COVID-19 season, where we realized that the flow of clients in our different drop-in centers was diminishing. And of course, we also know that during this period, we had closure of hotspots that really hindered service provision at those hotspots. So we adopted this innovative approach to ensure that there is sustained and continuous HIV service uptake and delivery to our clients. We also embrace home-based service delivery to our key population, and this is majorly done to those who feel it wise to access the services from the comfort of their homes. Why? Because of different reasons. One of the reasons could be, or rather have been, that they are closeted and they wouldn't want to be associated with different public spaces, including drop-in centers, public health facilities, including hotspots. So they would prefer that the services be taken to them at the comfort of their home. Next slide, please. And I'll list among some of the services that we offer through these approaches, and the services include health information dissemination to our peers. This is being done through health talk sessions. We have health talk sessions being done at the community level, some of them being done at the drop-in centers. And of course, we also do this through online platforms, including Facebook, WhatsApp, and other dating sites. These are being spearheaded by the peer educators, the paralegals, and the outreach workers. The health education is being done majorly to give information, knowledge, and skills on how to enhance prevention on HIV. And of course, we're also measuring on other gender-based violence related incidences in terms of preventing gender-based violence, in terms of responding to gender violence, and of course, human rights violation documentation and identification and response. We have condom and lubricants being distributed and being promoted at the outreach through clinic. We also have HIV testing services, including HIV self-testing. We have STI screening and treatment being done in different locations. We have the outreach, we have the drop-in center, and of course, when we also go to homes, different homes. We have TB screening, we have PrEP intervention, and PrEP intervention, we have screening for PrEP eligibility. There's enrollment, and of course, there's refill for those who've already enrolled into the program. We also have nutritional assessment and counseling services. We have mental assessment and counseling services. This was majorly realized at the time of COVID-19, where most of the clients were rendered jobless, and there was a lot of mental health concerns that needed to be addressed. MAAYGO worked closely with different partners to ensure that our beneficiaries well-being is addressed through carrying out mental health assessment sessions, and of course, identifying some of the mental health issues that can be addressed and doing follow-up through the mental health counselors. We have ART services, including refills and support group sessions. And of course, we also have response to GBV incidences. Next slide, please. On to some data. We have a model of service provision, and this data is for the period January 2020 to December 2020. As you can see, we have two major approaches of service provision. We have the outreach and the drop-in center. And I just want to give a comparative analysis of both of the approaches. In the bars, we have the blue color and the pink color. The blue depicts service provision at the drop-in center, and of course, the pink color depicts service provision at the outreach level. The reason we are doing this is because with this provision of our drop-in centers, it's rather prudent for us to ensure that the 70-30 ratio, rather percentage in terms of service provision at the drop-in center, and of course to the outreaches. So we envision having 70% service delivery at the drop-in center and 30% at different outreaches. So as you can see, in Q1, we have 531. We had 531 clients, or rather peers, being reached at the drop-in center, and we had 289 being reached at different outreaches. This goes on in Q2, Q3, Q4, and lastly, just a summation, or rather summary, we had 2,905 clients being reached at the drop-in center, and of course 1,069 clients being reached in different at different hotspots during outreaches. This is close to around 60 to 70% of DICE optimization. Next slide, yes, thank you. I'll take you through prevention cascade for the same period, that is 2020, January to December. And the total number of peers that were reached in the year were 2,328. Among the peers that were reached, those who were tested negative, or rather, those who were tested negative were 1,737. And those who were screened for PrEP eligibility were 1,729. And those who came back for PrEP refill were 250. We had 1,651 peers receiving condoms over the period. We had 493 peers receiving lubricants, and
Excuse me, Migot, you're muted.
am I still muted? Hello.
I can hear you now.
Where did you lose me from?
From
I think it was the
The start of this slide.
The prevention cascade.
Yeah.
Okay, thank you very much, Solo. As I was mentioning, the prevention cascade cuts across how MAAYGO has been offering HIV prevention services to our clients. And of course, over the year, that is over the period that is from January to December 2020, we had a total of 2,328 clients being reached, being actually contacted. And among the total number of clients being contacted, we had 1,737 clients being tested negative. We had 1,729 clients being screened for PrEP, and out of that, we had 250 coming for PrEP refill. The number of peers receiving condoms was at 1,651, and the number of peers receiving lubricants was 493. The main reason for the 493, as I mentioned earlier, was because of the low supply of lubricants, which was basically a national crisis, and we believe this is going to be sorted in the near future. We had 112 cases being reported, GBV cases, and of course, out of that, we had 105 being fully addressed. The reason for the difference is because some of the cases are still underway, and they are still being followed up for full addressing. Next slide, please. Okay. So among the challenges and learnings that we've obtained over the review period, of course, when implementing differentiated service delivery approach, some of the challenges we had is actually related to the available resources that we have. And specifically, we are talking about financial resources and human resources. The human-centered approach has different needs, and of course, this requires a lot of human resource in terms of addressing some of the specific needs of the key population at the community level. For instance, if you are going to utilize or adopt different types of client-centered approaches within one program, it really requires a lot of human resource to actually be utilized in offering these services from different approaches that we are adopting. When I talk about financial constraints, I mean these approaches, in as much as we are envisioning not actually burdening the healthcare system, but most of these approaches need some financial provision, or rather support, to actually ensure that the services are tailored to the needs of the key population, and the services actually reach the key population without them being burdened. So if that is addressed, I believe we'll upscale service provision through DSD model. This insecurity, this has been experienced in some of the hotspots, of course, when addressing violence incidences. There's a shortage of commodities I just talked about, and I think it's a national crisis that needs to be addressed. There's a pandemic like COVID-19 that affected most of the service delivery during the review period. Some of the learnings that we had over the period include DSD model, helping us to reach the hard-to-reach clients. Those are the closeted clients, because we adopted different approaches as directed, or rather determined, or as advised by the key population themselves. So it really helped us in reaching those who couldn't actually come to the clinic, those who couldn't come to the outreaches, those who couldn't come to different hotspots. There is improved retention on ART, and of course, this was done through ARV refill and during the PSSG sessions. There's also improved PrEP uptake. There's enhanced confidence and trust of the community. There's made services accessible to the key population with the utilization of different approaches that address the specific needs of the key population. There's reduced burden on the drop-in centers, because not all the peers are now being seen at the drop-in centers. Some of them are being seen in different locations. Next slide, please. I think this should be the last slide, and I just want to give few recommendations that we believe as a program, if we adopt in the near future, we are going to enhance quality service delivery to our key population. And of course, we are going to upscale a differentiated service delivery approach to address specific needs of our beneficiaries. First, the strategic partnership with the NASCOP, County Health Management Team, law enforcement agencies, judiciary, member of county assembly, LGBT, and SSW, that is sex workers organization, the media, community gatekeepers, and other key stakeholders. There's need to enhance that strategic partnership so that we can consolidate our ideas, we can consolidate our funds, and our resources to ensure that we provide the best in terms of ensuring that DSD is a success. There's continuous engagement with the key population community to understand their needs and receive feedback on the services. This is a majorly talking about the provision or providing the space for the key population to give out a voice, being involved in the process of planning, being involved in the process of implementation, so that we address specific needs that come from the key population themselves. This can also be done through operational research, can be done through baseline surveys, can be done through endline surveys, just to know what are some of the specific needs that we need to address moving forward as an HIV prevention and treatment program. There's integration of key population services within government public health facilities. If this is enhanced, we envision sustained service delivery beyond donor support. And of course, there's also creation of enabling environment within different public health facilities that will enable the key population to freely access the services from the public health facilities. Engagement of different partners and key stakeholders to address the shortage of commodities. I think this is a conversation that should be ongoing, and I believe it's ongoing, so that we address this, because it's been a challenge, of course, when it comes to enhancing prevention of HIV at the community level. That is through distribution of the commodities to our peers. Utilization of NASCOP approved key population standardized tools. This has helped us in terms of ensuring that there's a proper documentation, proper data collection at the community level, and of course reporting to different stakeholders and of course to the government, which will then inform the next action in terms of analysis of the data that have been presented, and of course making informed decisions based on the data that have been coming from the different KP implementing partners. There's lobby for more funding allocation to support drop-ins, different sources, and I believe the same information still applies to this point. And if possible, we lobby from different angles to ensure that there's enough resources to help us upscale the implementation, adoption and implementation of differentiated service delivery in terms of, in view of ensuring that there is quality service provision to our beneficiaries. That was my time. Thank you very much.
Thank you so much. Gloria, the next session is yours. Welcome.
Yeah, thank you so much. Thank you so much, Team Kenya, Mike, Onesmas, and Manas. I think it's been a great learning session, more information sharing and understanding what Kenya has been doing so far on prevention and KP, combination prevention and KP programming in supporting the differentiated care models that we're working on. So I will open this session for discussions, questions, where you see where we can learn more, what you feel like we could scale up. Yeah, so I'll open it. I have Lillian. Kindly go ahead, and then Dr. Margaret. Lillian?
Yes, hello, I'm Lillian from Zimbabwe. I was really impressed. Thank you for the really great presentations. I was really impressed with the way that your KP programming is very structured, especially with the ability to really report cascades from what is happening within our peer educators, because sometimes the peer component of KP programming sometimes is not as structured, and seeing it in cascades is really, really impressive. So I had a quick question for you as a country. I noted, I think it was the first presentation where I noted that you are testing your KPs every quarter. What has been the yield like? Because us as a country, we've shifted to test them twice a year because we realized the yield was getting really, really low with frequency of testing. So I'd like to hear that from you as well. That's my comment and my question. Thank you.
Thank you, Lillian. Please, Margaret.
Hello, good morning, everyone. Thank you so much, Kenya, for the very well elaborated presentation. I had a lot to learn as a neighbor here from Tanzania. I have some concerns just to clear so I can know how to implement in my side. One, do you have I wanted to know if do we have any minimum package we can say this is the services we really need to give to the population we target, to the KP. Do we have minimum package which completes the service and say now we have given services to the key population, like maybe when we reach 3 or 4 among the minimum package, that's we say the services have been provided. Do we have that? So I can know which service to pick, or do we pick just any service we get, we say this is the service we're providing, or that explains the combination of prevention as you said. That's one. Another thing which I was glad to see, it was like you consult the users, the KP. I wanted to know, do you have any legal channel to communicate with the KP? As you say, this population is still have issues on legal issues. So it's like looking at how do you make the consultation to them and reach consensus. This is what this is the way we want. This is how we'll go. Do you have any form or legal communication to communicate with the KPs to get information from them so that the DSD to be more of effective, as you said? So I have some few questions. How do you get data to the HIV self-test? Do they come back, or we just give them the kits and go? Do we, because I'm facing challenge in terms of KVP in my side, to get if they're tested with HIV self-test, how do I know they're tested? Do they give feedback? How do you do that? Probably I can learn and see how to improve in my side. Another thing, do you give, you said you give condoms and packages. Do you give for free? I wanted to know, do you get scarcity in terms of condom programming by giving this, the KP people? With the training package, you said on the prevention of violence. Who do you targeting that? I saw the training package. Maybe I missed something. Who do we really target on that, on the violence part? Who do we want to train on that part? But I'm glad for the recommendation you put it on table. Thank you so much.
Thank you, Dr. Margaret. I have no further questions so far. Maybe we'll take those back to the team. So Dr. Ekisa, Onesmas, and Manas, maybe just to clarify. So basically, looking at the quarterly testing we're talking about, the minimum package, how do we do the formal legal consultations? How do we collect data for self-testing? Do we ever run out of condoms in our combination prevention package that we give for key populations? And then who does our target when we do GBV? Helga or anybody of the team members? Thank you.
So this is Onesmas. I want to attempt to answer one or two questions before passing it over to my colleagues to also answer the rest. There was a question from Dr. Lillian about quarterly testing. Yes, in terms of yield, from quarterly testing, the yield is low. I analyzed data just from LVCT from 2 counties, and the yield from quarterly testing was 0.01 or 0.1. So yes, that is low. However, also why we continue to provide quarterly HTS, alongside other services within the package, it's because we look at it as prevention. Yeah, and prevention is the goal of prevention is for people also to change their behaviors, and changing behaviors is not a one-off thing. So if we look at quarterly testing, we look at just the yield, then we might lose up on prevention. So, but if we look at prevention, then there will be the continuous need to continue providing HIV prevention services. I'll I will let someone else comment on the issue of the minimum package, but I want to also talk about HIV self-testing and how the people who collect HIV self-tests, how we get back the reports on whether they tested or not. First is just to comment on our approach for HIV self-testing. We look at when you collect the test kit, you go and either take to your partner or whoever. We look at it the same way when you collect a condom. Yeah, so the achievement, or what we consider achievement from HIV-ST, is not entirely whether you reported back or you did not report back. The same way when you collect a condom, we expect that you will go and use the condom. And since you collect freely without any pressure from anyone, then we assume that you actually needed the service. At LVCT, we have had the people call back to report, either through the drop-in center contact or through, we have a call center where KP have a toll-free line where they can call back and report, the 1190. So people are able to call back within that. Some call back to just ask how to use the kit. Some call back to actually say, I have tested and I'm HIV negative. And then some also call back to say that my test was HIV positive. And so I think I've answered that. Are condoms given for free? Yes. Condoms are provided by government. And so we are able to do requests. So we just write to NASCOP, for example, they give an approval, and through the government distribution channels, we're able to go and collect condoms for free and distribute for free to to our clients. Yeah. So let me allow my colleagues to respond on the rest, or even to add on what I have said.
Thank you, Onesmas. I think I will ask then Pari, because I don't see Helga. Yes, we do have actually minimum package for key populations. Parineto, are you here? Can you speak on the package that Kenya offers? Thank you.
Thank you. Thanks, Gloria. Just before that, Lillian, I was just typing a message for you. I think Onesmas has very, very clearly addressed your issue. I'm very passionate about quarterly testing, so I'm coming in again. That at the national level, we do see 1 to 2% yield. And the yield is much higher in counties or geographies where the program is starting new. Like a county like Kiambu, we see up to 6% yield among MSM, or when we start program with new populations like transgender, we see very high yield. But just like Onesmas said, for us, HIV testing or for a key population program in general is a prevention program. So we don't see testing is testing and treat. We see testing as prevention and treat if you are positive. And that's why we have insisted, and we have had a lot of challenges in some ways with PEPFAR also, who's one of the bigger donor, but we have insisted that we need to do quarterly testing because testing is the entry to prevention for a lot of our key populations. But at the same time, testing is also a space where people come into DICs, meet other key populations, share about their issues. It kind of provides the opportunity to meet other people and come and look at also other services. That's why we have kept it quarterly. In terms of Dr. Margaret, about minimum package, yes, we do have a minimum package. Our guidelines actually in the GPC website. So we have, initially we started with a minimum package for FSW, MSM, and and PWID. And in 2020, we started, we did our guidelines with minimum package for transgender. In terms of, I think your question was also, how do we count whether we have provided that minimum package or not? We normally follow the UNAIDS definition on coverage, where UNAIDS defines coverage as a population, a KP is covered if you have provided 2 services in the last quarter. And the 2 services, you can consider any 2 services. So it could be a condom distribution, or it could be also clinic visit, or any other service that you provide. So we count coverage as 2 services, and these 2 services should be the defined services within the guidelines. But in terms of monitoring, we monitor the whole package of services that we provide, and a package of services we have split as behavioral, biomedical, and structural, and we have also split as essential and desirable. So we, in our reporting formats, we monitor all the essential services that we are expected to offer to key populations as per our guidelines. But when we report to UNAIDS on the coverage, we talk about at least minimum 2 services that we provide. I hope that is clear. Thank you.
Thank you, Pari. Solo, please go ahead.
Yes, thank you everyone for joining in the meeting. So I wanted to add on the whole KP engagement. So as key populations in Kenya, we have, should I say, platforms of engagement with, with NASCOP and NAC. So we have the Committee of Experts meeting that is used to be called technical, just hold on. Technical working groups, whereby we look at data. We have a conversation on the country project and also how it's actually going on. So it is our space. And then we have the meetings like quarterly, yeah? And also now we have counties. Hold on, Amari. Now we have counties in Kenya. So we also have the county engagement, whereby our organizations, that is the key population organizations, also interact with the county health personnel. So at least those are several areas that key populations are engaged as. Migot, you can add.
Yeah, please, Manas, can you go ahead? I see your hand too.
Okay, so thank you very much. I think Pari, Solo, and Onesmas have tackled most of the questions, and I just wanted to reiterate from the point that Onesmas gave on HIV self-testing, how we track, and of course, how we get the data. First, I'll give a case scenario of MAAYGO, having that we did a study on the same, and of course, we had a lot of learnings throughout the study. So for us, we developed a tool that helps us to track the provision of the commodities to our peers, and of course, tracking of how they've been used, and of course, how to get, or rather how to refer the clients who've come for confirmatory tests, whether to refer them for prevention or treatment services. So from the tool, when a peer is being issued with the HIV self-test kit, he gives the mandate, or rather gives the authority to either the peer educator or the service provider as to who should do the follow-up. Upon delivery of the kit to the peer, there's a grace period of around 2 to 3 days that is being given to the peer to actually use the kit and give the feedback to the healthcare provider. If the peer is okay with the peer educator and feels like he wants to communicate to the program through the peer educator, well and good. So if the 2 days elapses and there's no feedback to the program, whoever was mandated to do the follow-up, basically it starts with the peer, with the service provider, but of course it can also be done with the peer educator. But the service provider takes the initiative of making calls to the peers that were issued with the kits, just to get to know whether they used the kit, how was the experience, and what were the results, and if they would wish to be enrolled into the program, because this study was targeting the infrequent and non-testers. So we would want to enroll them to either prevention or treatment services or program. So upon making these calls, the peer will now give feedback as to whether the kit was used and what was the experience and what were the results. If the service provider tries to reach the peer and it fails, it gives it another try after around 2 days. And if it still fails, then the number is given to the peer educator, who makes further follow-up through phone call and of course through physical follow-up. So if the peer educator tries to reach the peer through phone and it's not possible, the peer educator will now visit the peer at the community level physically to see what was the experience. So in as much as we deployed, or rather employed, these strategies, but we still had some few numbers of those who used the kit, but didn't give their results, which is a challenge, as mentioned by, I think it was Esther. So, but many of those that we've distributed our kits to have been tracked. And of course, we've received their results and we've linked them to either prevention or treatment program in our clinics. So that is the channel that we use to ensure that we track and get data for HIV self-testing.
Yes, thank you, Manas. Just maybe also to add on the issue of the GBV training, and if somebody else in the house can add, yes, our GBV training is actually 360. So basically the beneficiary, the community, the training, the facility, the nurses and the community facilitators, including the police in the community, and those everybody and anybody else who is actually very who supports the KP programming. So it's 360 depending on the county we are, or depending on the community we're serving, and looking at the entry points or where we have issues or problems with the when it comes to GBV and the KP, we ensure that we give trainings and we give support to the population within, and also the people who make decisions within the community. So it's actually a 360. So we try to reach everybody when the needs arises, and we work with all members of the community to ensure that actually the program works. Dr. Margaret, do you have another question, or is this an old one? And Lillian also. Thank you.
Yes, I do.
Okay, thank you. Go ahead.
Thank you. Thank you so much for actually the response has been given. I had a lot to learn around that. It was interesting that on the HIV sector, I'm interested because that is something I'm working on now as a head of prevention, and testing is very important to this client. So maybe a takeaway home, like this to correct this data is an issue in terms of the results, what was the results and everything. Probably we can get this from the NA survey, which can be done in the country. That should give us a more of information. That is my thinking. Another thing, maybe I was looking at the FSW in Kenya. It's very different from Tanzania, because the FSW in Tanzania, they are very cooperative compared to any KVP other KVP population. So it's really interesting that when you look at the data and the approaches, is bit like the FSW in Kenya is a stubborn. I can't call that, but it's a challenge to approach that group. So I was like having a last maybe something to learn from you guys. I wanted to know on the PrEP. You said you screened PrEP clients. They were like 7,000. So I was thinking, like, do you have a screening tool and eligibility criteria for those groups, or every KVP given PrEP? Or do you, considering that is HIV negative, or do you have something else beyond being HIV negative? That's all I want to know. Thank you so much.
Thank you, Margaret. Pari, you have your hand up. Please go ahead.
Yeah, thanks, Gloria. I just wanted to make a point on HIV self-testing. And just because Dr. Margaret is interested in that, I just wanted to say that our studies and research in Kenya show that when you start HIV self-testing, the first people to move towards self-testing are people who already are testing through the rapid testing and coming to our DICs, right? So we were very clear that our objective is not to move already testing people to another mode of testing. Our objective is to ensure that people who don't test and KPs who are infrequent testers are given self-testing, because there are certainly barriers for those people to come to our DICs and test. So I think our learning is that self-testing is a great option, but I think it is also a good tool to reach hidden population and link them up with general services because there are certain barriers because of which they are not coming to our standard services anyway. So it could be very, very targeted tool to be used. Just wanted to make that comment. But I think for the PrEP question, maybe Dr. Mike, if he's around, or I see Helgar is also around, we could talk about it. Thanks.
Thanks, Perry. Helga, would you like to speak about the PrEP and the testing and how we do the criteria for, especially for KP? Or maybe I ask Victor first to ask the question. Victor.
Yeah, no, I just wanted to respond on the issue of the PrEP.
Okay, go ahead, please.
We have PrEP as screening tools. We have SOPs, and not everybody who tests negative will be enrolled on PrEP. Maybe if they are maybe as high risk to HIV, and then they'll be enrolled on PrEP. And also, we also initiate client-centered approach for PrEP. Not everybody who's negative will be enrolled, but only maybe KP who are at risk for HIV will be enrolled. And we also make sure that it's client-centered approach, so that we don't also give PrEP and they go and throw PrEP, or maybe they go and sell it. So it's more client-centered approach in terms of PrEP enrollment. Over. Thank you.
Thank you. Onesmas, please go ahead on the PrEP.
Yeah, my comment really not on PrEP. I think it's been answered that we have a PrEP eligibility or screening tool. So we do screen, and those who are eligible then are enrolled for, but not everyone. Not every HIV negative person is eligible for PrEP. I wanted to comment and just clarify on the notion I may have created that sex workers are stubborn in Kenya. That is not true. Sex workers are generally cooperative, but just to say that those that we enroll on DSD or those that we come up with alternative ways of reaching them are those who have difficulties in either accessing the drop-in centers or the facilities where we provide these services, or those who are planning to travel for long periods of time. Yeah, but so the word is not that sex workers are difficult. Yes, they are very cooperative, but then we have a few of them who have particular challenges accessing services. So that's the clarity I wanted to make. Thank you.
Thank you, Onesmas. Any other questions, clarifications from the team members on the conversations that we just had and how the KP program works in Kenya? What surprised you? What impressed you? We've had a bit of that. If anybody else wants to, any more further clarifications? If not, then I'll just hand this over to Helga. Thank you. Oh yeah, I have one more question. Just for if we're doing for violence packages, if we work with the question is if at the diocese, or how does our integration work with GBV? We also have like a, oh, that's answered already. Thank you. That was answered already. It was just the integration, integrated SRH, HIV, and GBV in the diocese and how it's done. So I think that has already been answered. So thank you very much. Janet, do you think Helga is around so we can take the next session?
I am.
Thank you.
Sweetheart.
Sorry. Maybe I was not hearing you because please go ahead, Helga. I'll just hand it back to you. Thank you so much.
Thanks, Gloria, and thanks. And I think those are great reflections and coming from national, county level, and also at the implementation level. And very insightful questions and clarifications and insights from the other teams. I think just to add on to the discussion about the self-testing, I think for Kenya, we introduced self-testing. We actually were using a slogan of getting people from the holes. And as Pari is saying that we have routinized our testing, and we expect every key population to be tested every quarter, and we have evidence that that is very beneficial for our prevention program. And what we did was that to use the self-tests to get those people who routinely would not come for the quarterly testing, who would not be found when we go for outreaches, and maybe the partners, either of the sex workers, of the PWIDs, and for the MSMs, and would allow get a buddy to get a buddy, so that you bring your friends to the clinic. Self-testing was also used, and we had an activation. We had very many activations, especially with the MSM programs, where we had on Facebook, they would do some activations, have music, and in the interlude, they would now tell people you can test, they would demonstrate, and then people would call in online and say that they want their test kit delivered on these in this place. So I think we actually made the self-test really look fun. I think the challenge remains, and it's globally, of how to really track. But one thing we said is that as much as you improve access, you're able to navigate through some of these challenges. And very soon, self-test kits will just be like condoms, because we don't really follow up. Did you use a condom, really? But if we improve access, it means that everybody will be able to get a self-test, and those who are positive, we're able to link them. So the big thing is just to make a system for really identifying the positives and making sure that they are put on treatment, and ensuring that the negatives actually have a positive living attitude to ensure that they continue being negative. Let me also talk about because PrEP was also a challenge, and especially because for Kenya PrEP, we took a general outlook, because we didn't want to start PrEP from a stigmatizing area. And we actually rolled out PrEP for all, but we basically, of course, made sure that we have some of the key populations and other groups really concentrated in terms of our intensifying of our efforts to roll out PrEP. But it came out as a general outlook. However, we know that initially the criteria we were using then would ensure that all key populations are actually eligible for PrEP. So over time, we've been able to tighten that criteria, and only those who are motivated enough and those who are who know that they are clearly at risk are able to take PrEP. So that has really helped us in terms of improving the quality of the services that we provide in terms of PrEP. So allow me at this juncture to go to the tail end of our webinar today, and really is to ask, thank you, for any final thoughts, takeaways from the different countries. And I'll start from Nigeria, then we go to Zimbabwe, and then we go to Tanzania. And Kenya, you can give us your last takeaways, if any. Then we'll have a summary from the SSLN team to complete the webinar. Thank you very much. And Nigeria. Do you have final reflections from the country team, Nigeria?
I see that Dr. Oki is here. Sorry.
Okay.
Yeah, let me thank the country for a very insightful and very insightful presentation. It was interesting to see the different models and how well delineated the models were with the services and the practical implementation of them, and the fact that records were being kept very well with tracking tools for each of the different models. And for us here in Nigeria, that's a great takeaway from this. One of the key challenges has been having robust monitoring tools that can track for the different models of the DSD. And I think that's something that we're relying on Kenya to look at their tools and then modify accordingly for the country programs here. Also, the variety of the models, was quite interesting, differentiating between different kinds of models and then the services provided within the models. Those are very great takeaways from this. But like I said, one of the key things will be to look at the tools that has been used to capture the records in this very particular programming effort. And I think that's something that the country here will take away. And we look forward to getting that from Kenya and then probably some assistance too in developing the domesticated ones. Thank you. Thank you very much.
Thank you so much. We have Oki. You can see your hand up.
Yes, thank you very much. This is to appreciate the speaker. This was a very interesting and enlightening session. I agree totally and completely with Dr. Green, so I will not go over what he has said. And I think in Nigeria, we have learned one or two things which we will put to use. Thank you. You'll have a nice day. Bye.
Thank you so much, Oki. Okay, do you have any other submission from Nigeria before we move to Zimbabwe? Okay, thank you so much. The next team.
Thank you very much. I think one of the take-home points that I really got, as I mentioned before, was the really structured way that the prevention and the treatment cascades are really reported. I was really impressed that they could actually track the services received from the contacts to the number of peer education, to those receiving peer education, to those receiving condoms, to those receiving lubes, and the various screenings. So you really have a full prevention and a full treatment cascade. I think for us in Zimbabwe, that's something that I've learned really well. We are offering these services, but to be able to put it together in a formal cascade, it really tells the story better. And that's something that I really learned. Thank you very much. And I think as mentioned before, I think an area that we really could learn from you guys as well is the structured way that you're doing your CAGs, and also quality improvement for CAGs, being able to monitor CAGs, especially when you're talking about peer-led models of CAGs, being able to monitor them, being able to have clear quality improvement indicators, and being able to be really structured about CAGs the way you are. I think it's something that we really look forward to really further collaborating and learning from you. Thank you very much. It's been a really insightful presentation.
Thank you too for the compliments. Do you have any other submission? Okay, let's go to Tanzania. Thank you so much for those great insights and compliments. Any more submissions? Okay. Kenya team, anybody who wants to say something before I hand over to the SSLN team?
Helga, just to appreciate our visitors for joining us today. And we are honored and we look forward to continuing to learn from SSLN. Thank you very much, Dr. Mike Ekisa.
Thank you so much, Mike. So let me just give my two thoughts about the whole DSD program. And really to say that one thing that we have learned over the years is that number one, if you really want to tweak your services to meet the needs of the community, listen to the communities, and therefore you have to give them those forums where they can speak freely and tell you the difficulties that they're getting, maybe in getting interventions, and maybe also to tell you the good things that you have done that you can scale up. And listening to the community voices has really been very key. And even some of these DSD models, it has been because the community has told us that if you come this way, you're going to reach us. If you come this way, you're not going to get anyone. And sometimes we've even had to close our dropping centers when the community tells us that that dropping center is not going to serve the needs of the community. So it's important to listen to the communities. And you've seen the peer approaches and peer-led models are the ones that are really helping us in terms of moving the DSD agenda forward. The next important thing is to just have clear and timely guidelines, SOPs at the program level, so that can standardize the way you're providing the care. And you can see for the Kenya, everybody is implementing similar things with the same standards. The national guidelines has detailed even the way you do the peer ratios, and we have given you for MSM, it is 1:41, peer takes care of 40, and you have tools that you're able to even make sure that you see your peers every now and then. And then we've even standardized the stipends. And nationally, we say that this time round, we are going to pay these stipends based on the market rates also and some of the considerations. And then we also tell you peer outreach workers, you're paying this is what you pay the peer educators, and this is what you pay for the other cadres. So we are able to give very clear guidelines so that there's standardization across board. And this came across when we used to find some of the implementing partners paying more, and would have peer educators really go to that implementing partner who is paying more. But with the standardization, we are seeing a lot of retention of our peers because everything is standard. Lastly, I think timely capacity building efforts. If you want people to do the right thing, then give them that information and the skills to run it best. And if you do the national outlook and use the existing curricula, then you know that you're going to have standardized way of doing things. For me, those are three critical issues that you will not go wrong if you follow them. The others, of course, are good insights, but the three components that you really need to ensure that you have on board are those three for me if I was to really have a take home. So thank you so much, and thank you for trusting that Kenya would give you a DSD. We never thought we would hack it. We actually didn't think we have any DSD. But you've challenged us, and you were able to help us think out of the box and really identify the DSD models that we have in Kenya. We hope to have other topics from other countries, and I know we are going to learn a lot from the other countries that will be identified by this great team. So at this juncture, allow me to thank all of you and to thank the great contributions and insights that you have given unto us, and really looking forward to having greater engagement. So at this juncture, please, I would allow the SSLN team to take over so that they can give us the next steps and moving forward, and also to close for us the meeting for today. Thank you so much.
Thank you so much, Helga, and to the entire Kenya team. I think you hosted a really excellent session today, and I really want to share my appreciation. Also, just to thank the participating countries. I mean, these sessions are for you and for learning, and I hope that we managed to support in achieving those objectives today. I recognize we're slightly over time, so I don't want to keep you, except to say that the South-South Learning Network here really is available to everybody on this call to support further learning around differentiated service delivery for key populations. What this means is that any country who would like further bilateral meetings with any of the other members on the country, we would be happy to facilitate that for you. If there's a requirement for a follow-up discussion on differentiated service delivery, again, we'd be happy to facilitate that. All you need to do is reach out and let us know. Furthermore, we will be writing up this promising practice today as a case study so that we're able to share it with you all to reflect on further and perhaps in slightly more detail. We'll also be sharing the presentation and the recording of this meeting, as well as working with the Kenya team to try and consolidate all the many really excellent documents that were shared with us today, so that they may be available and assist countries where you might be embarking on a similar journey and developing similar documents. And just to say that all the colleagues' contacts will be made available to everybody on the call so that you can reach out bilaterally to your peers across countries. I hope through this call we were also able to familiarize some of the members in the key population South-South Learning Network with one another. And you're also welcome to reach out to the Learning Network ourselves if you'd like any introductions or relations for us to facilitate that. Yeah, lastly, just to thank everybody once more. I think this is just one other step in a journey that we've been traversing over the last year and we'll continue with. We would welcome any inputs on how to improve these sessions, or any ideas on additional link and learn sessions that you might be interested in. So with that, I just want to thank everybody again for this meeting. And Helgar, I will just I will close the meeting because you asked me to. But yeah, once again, just thank you to the hosts. And,
thank you.
Yeah,
thank you so much.
Well, thanks everybody. Bye.
Bye.
Thank you very much and bye.